So today we will talk about the facets, the functional modules, the data model, the tables, the most frequently used, and then we will go through the pricing, the workflow, and the DRG pricing. Mostly today's session revolves around the pricing and the facets tool. We can't have a real-time or a demo version of the facets, but at least I've captured some screenshots. In most of the cases, we will be having some limited access to the facets. Not everyone has the full access to the facets. So in that case, most of the time I was having only the read permissions, and I was able to capture some screenshots to show you all. So today's session would be like in case if you are going on to a project as a configuration analyst or a facet SME, then today's class would be kind of important to you to know what data you need to be prepared with, what are the factors that you need to know, what are the programs within the facets they operate behind the scenes for which you need to configure. So that kind of information will provide some basics to you. So nevertheless, you need to refer the facets manual, which will be like a configuration manual to get the more details about it. And also in conjunction with any organization's business rules, you need to know before you start applying those parameters in terms of your configuration. So today's session will provide you some kind of a basic so that you know, okay, these are the programs, this is the information, and this is the way the pricing operates. And we will expose you to the data model also. Okay. So before moving forward, any questions that you have? Okay. So we have a good audio and video, right? You're able to see my desktop and you're able to hear, so we don't have any issues. So we will proceed further. In the previous classes, the previous batches too, there was participants were asking to give a one page of a transaction that can give us a good picture. So that's the reason I have added this. If you see on there are some, I have highlighted those segments into like a boxes. The first box will tell you the segment detail. It has those transaction header, the receiver name, like it has the loops here, 1000A, 1000B. Let me also show you. I'll split the screen. Okay. Right. Yeah, this is what I'm showing here. For example, on the left screen, you have a segment detail, right? 1000A and 1000B. So if you look into any typical file, transaction file, so you will have those numbers here. For example, 1000A, you have payer identification. Then if you look at 1000B, the payee identification. So that's what you're seeing here, receiver name and ST, right? And if you further go down, then there are some billing details, 2010AA, 2010AB, 2010AC. If you further go down here, 1 second. Okay. So these numbers here, like 1000A, 1000B, pertain to your submitter name and receiver. Then you will find your billing hierarchy here. For example, 2010AA and 2000. So you will find here 2000A and 2010AB. So you can find and correlate each and every segment and a loop. So you can really understand, how this layout looks like. So I'm scrolling down this transaction here. So let's go into the loop, like a claim information. Okay, and I'm scrolling the PowerPoint to go further down. So at 2000 loop, you have the subscriber details, and then you have the patient details. At 2003, and at 2300 is your claim information. So if you look into this clarity report on your right side, so here is your 2300 claim information. Okay, so claim number and all those details are here. So here you're seeing horizontally, like line number 26, and then on the left on the PowerPoint, each and every element is one below the other. So that's how the mapping is done here. And this is for your understanding how a transaction element can be mapped from a transaction structure from a manual. Claim details. Then if you further go down, then you have your rendering provider information, primary care physician. So those information are under the loop 2310 and 2310E. Okay. So I'm scrolling further down here. The service line details are under loop number 2400. So let us see in the actual file where they are, 2400. All right. So you see on the screen on the right side, 2400. That's your LX1 represents the service line number 1. LX2 represents your service line number 2. So this particular transaction file has 2 service lines. That's what it means. Okay. Right now I'll switch on to the PowerPoint slide mode. I will be sending this as a separate file. I mean, not as a PowerPoint recording. This particular page, so that you can print it out and a A3 size page, in case you want to look at it. Because if you look into any manual, they will not give you in one sheet. It will be in several pages. So that's the reason I thought, it will be useful for you to have all such information put together in a single page. Okay. So now we will look into this.
Raghu, have you put the other Word file in the blog?
Yes, sir. 3-4 documents I have put in the blog. So I was able to see, were you not able to access those documents?
No, the old document that you are comparing right now. Have you put that one in blog?
No. The one I'm showing today, I will put it after this class. So it's not that yet. I will put it.
Okay, thank you.
All right. So what you're seeing on the screen is a data model. The actual data model of the FastAct, if you see, it runs into several hundred pages. So obviously that would be very difficult for us to review it. So for that, what I've done is, for example, if you're working on a claims, for example, transactions like 835 or 837, which is most of the time that we work. So those tables that we commonly refer, I've taken them and designed into a data model so that, we can see in a 1 page or 2 page. Otherwise, going through the hundreds of pages would not lead to us. That would add to more confusion. So nobody in any organization knows how many tables there are, how they are connected, what they are. So all they would know is in the front end, so this is the claim information. It has got several lines of information. This is the remittance information. This is the subscriber information. So it's very hard to pinpoint and tell, okay, how many tables, where they are, what data it is. But at least, if you take a handful of tables and then show it as a data model, and that would give you a better understanding of how the data flows. And I would strongly suggest you to write some queries, write some SQL queries to access these tables. At least, find the table definition, find the top 10 records in this particular claim, or put up a small join and see how do you get the claim service line details if you know the claim number. So such kind of a small querying would really help you in your when you get onto your project. I mean, not to the detail of writing a PL SQL program, at least a small queries. Okay, so let me walk you through this table here. If you see, there are 4 columns, right? So these tables, the first one is your subscriber address. So all the information about the member, his address, demographic information are stored in this table. Then the next table is your provider registration indicative information. More information about the provider registration and all. Then CDML CL line is a claim line data. So all the service line details are stored in this particular table. It's called CL line. these names are as per the facets database. No matter in which organization you use or which provider organization or payer you use, you will be using the same table name. So these are consistent across. Okay. So there are other claims processing tools, but we are not discussing that. But we are taking facets as an example to give you an idea of the data model. Okay, at least you can tell if you are facing any interview, saying that yes, you are familiar with the tables, you know the data model, the tables, how they are linked up, what are the key information that is used when you are working on a claim. To that extent, at least you can confidently tell. Then the next table is your CDCD line COB. That means all the coordination of benefits information is stored in this line table, COB data line table. Then the one below is like a lookup table. All your codes are put in this table just for a reference, crosswalk reference purpose. Or if you know the code, you want to know the description, this is where you come. So under the column, second column, the table here we are showing is ACLAP claim as provider table. This is the custom table, so you will not find in other organizations, but there are other custom tables. Sometimes we define it so that it's easy to get the data. So this is a alternate provider table. Then the next table is your provider table. The complete information about the provider will be stored in this table. Then you have your actual claim table, CLCL claim. So this is where all the claim information about the member is stored here. Okay. Then the next table is your CLHP hospital. So all your hospital specific data is stored in this particular table. So similarly, you have a member table, address table, the condition codes, the ICD diagnostic codes are in CLMD diagnostic table. So I would suggest that you at least memorize 4 or 5 table names, in case you are asked in an interview. The claim is very, very important because that is the heart of the claims data. So remember CLCL claim, at least the second qualifier and third qualifier are different. Okay. So CLCL claim is your claim data and CL line is your claim line data. So that you can easily remember. Then you remember the LICOB, which is your coordination of benefits. And then you remember the ME member. So at least 4 or 5. You pick your tables of your choice, whichever you think you are more comfortable. And those things you can quote in your interview saying that, yes, you worked on a data model. These are the tables that I commonly use. Okay. Any questions on this data model? I mean, this data model is not provided in any facets, any manuals. So this is highly customized for our training purpose. That shows some arrow marks. And if you look into, if you are at a different workplace, you might have a slightly different arrow marks based upon the need. So these are kind of a color coded. And the IDs, mostly the claim ID is the common data element if you have to access other tables here. Okay. And there are some members here, MIMI CK, it's a member code, and GRGR CK is like your market. For example, there is a Blue Cross Blue Shield, and it has members in different states, like Texas, and there's a Colorado. So this CK is your code. Like for example, 2-digit code. It might identify California, it might identify the members of Texas, etc. So that's the part of the key. Okay. So here is a description of those tables that we just talked about it. So I have given some explanation about some 18 tables. So you can go through what data it contains. So just some 3-4 lines of explanation about these tables. Okay. Now we will talk about the processing, the claims, because when a claim is being processed in a facet, there are several programs behind the scenes that run, and these programs are configured in the beginning, and based upon the configuration, the price, the logic, the coverages are determined at the time of adjudication. So this chart kind of tells you what are the different programs that are applied and run during the adjudication process. So this information I have provided to you in 2 slides. The first slide is kind of a high level, and then the second slide, what I will be showing to you, has got a little bit more details on it. So the first, as soon as the claims are loaded into the facet, some basic edits are applied, to make sure the provider information is correct, the ICD codes are populated, and your NPI information, the taxonomy information is available, and if the referral information is quoted, it should be available, and if the modified information is there like 1 or 2, then in the place of 1 or 2 on the claims, there should be a diagnostic code, ICD codes. So that kind of a basic edits are checked. Then the member eligibility is checked, its coverages, whether he is active on the date of service, etc. Then the provider status, even the provider is validated to see that in what kind of a standing status he is in, to make sure that there are no other abuses, there are no other litigations, and if he is in a bad status, then probably the payer may not work with the provider. So if you want to make sure the provider is also in a good status and there are no other major litigation pending against the provider. Then there will be there's another program. There are different programs. One such program is called SCDF, which means the service definition part is applied. Then there's another program called DUMD, which determines the duplicate logic, whether it's the members as a duplicate, the service lines are duplicate, that kind of checks are done. The valid authorization, the referrals and authorizations are checked. The claim check edits, the much more detailed checks are done. Then there's another program called service pricing. Just like a service definition, there's a service pricing, what type of price to pick. Then the payment information. Then comes your COB, coordination of benefits, logic is applied. So these, to give you an idea, these are the different programs that are run behind the scenes. So you will see in the coming slides, I have captured the screenshots and see, what information is fed into the system. Okay, so from starting the time the claims are loaded and by the time the claim is adjudicated, whether it's denied or appended or paid or rejected. So these are the different programs that runs behind the scenes. So to see a little bit more in details about what the basic input editing consists of, like we could see that there's a subscriber ID is checked. Then your member names are checked. The diagnosis codes, the service provider, the charges, the place of service, the procedure codes, the revenue codes, all these codes are it's like a database where the CMS maintains it, and everyone should be able to use the same codes for consistency. So if these codes that are available on a claim are not found in those tables or the database, then it would totally reject the claim. So these are the basic edits. Then when you're checking your eligibility, you'll be checking for your member, your class, plan, group, etc. Then also you'll be looking for your network edits, whether you're in network, out of network, that kind of a thing. So these are a little bit more detailed validations that, that happens at the time of claim being adjudicated. Any questions so far on these steps that we are talking about?
Raghu,
yeah.
How this process will take? It will take the EDI data?
Yes. All this is coming through an EDI. So all the data that comes through an EDI, for example, for clearing houses through the web interface or the batch online, and whatever the form it is, not necessarily through EDI, it could be your manual process also, right? You could you can get the manual claims also, but majority of them is through an EDI.
So like if it's coming through EDI, so basically this assets like eligibility state, member, valid, these things, it will read that EDI code, asterisk and something. So like it will basically do that?
Yes, sir. It will go through the EDI process. It will read all the claims that are coming through the EDI, obviously.
Okay.
Yeah. So EDI is the heart of the system. So any transaction that's come to an organization, whether it is from a payer to the provider or vice versa, it is through an EDI. So here I've given some architecture, if you are curious out of it, and it might be useful in case you are working on a technical specifications on your project to know, how the facets of framework and architecture operates. So this has taken straight away from the facets manual that kind of tells you like a system architecture. So if you see this table here, it tells you that it is based out of Microsoft component object model, which is called COM framework. So all your interactive file servers and clients, they communicate through the COM and DCOM components. Basically it's the XML configuration files. If you see here your interactive server, file server, and your database. So most of the time, I have seen the SQL Server as a database, but also I have seen a Sybase, which the facets operate, and I was also told that even Oracle, it is good. So at least I have heard 3 different databases in which this facets runs. Okay, and obviously there is the connection that's called ODBC connection that connects the database. And if you are connecting through your file server and a database, you establish your ODBC, and that's how you connect and get the data, retrieve the data. This is a little bit more explanation how the application server communicates between the database and your front end, basically using the ODBC to get the data. And once you have the data, then you use your DCOM components to send the data. And nowadays there is, the web services are widely used to communicate and present the data. So that mode of transmission is via XML or SOAP or the different technologies that are available right now. Okay, so that was an architecture, and we have discussed a data model, and we have also seen some of these process steps of the claims adjudication process and the programs. And before we go into the programs, so let us see some architecture, how the facets defines the group, the plan, and all. So at a high level, the minimum requirement in which a payer defines with the provider is your agreement. So agreement is a key document that actually spells out your billing structure, your coverages, etc. So without an agreement, you can't enter any data, or you cannot process the claim for a particular number. It's so important. So that will spell out, sorry. All right. So the agreement will spell out the contract terms, and the contract terms will have the different calculations under which it is defined by the category, and it has some groups, and those groups, in addition to that, you have a fee schedules under which the claim has to be paid. Okay. So this particular model where you define your agreement and all is called your networks pricer. Okay. So here is a little bit more a definition of how the class is defined. Each and every class or a plan in a facet comprises of a different code tables. So one such code table is called a revenue code table. This has a revenue codes, and each revenue code translates to the appropriate billing. Then there is a service code table. Then there is a procedure code like CPT, HIPAA codes tables. So all these tables are tied up to how a class and a plan is defined in the facet, so that it can determine the right pricing. We talked about this revenue codes and HIPAA codes, right? Here is an example just to show you how the different charges are applied. For example, the column here, it shows the revenue codes like 021, 262, etc. So just a numeric code, revenue code. Then it shows a description too, what this each code transforms into. Then if there is any HIPAA code associated with it, for example, your X-rays has a HIPAA code, so we got a HIPAA code. And the quantity here, how many such supplies is 4 supplies, IV services 6 times, the bed is 1, and the charges appropriately. So it's always the rate times the quantity will be getting your charges. So this is just as an example, how these revenue codes will lead up to the total charges. Okay, so this is another a continuation of the definition how a group, a subgroup, class, and plan is organized. So any facets, no matter whether you are working on a provider or a payer, that's how it determines. So first, at a very, very high level, is your group. Group is always, like at the state level. But in this example, Texas is one of the groups they have identified, right? So it's a very high level. They always go by the state. They call it a market. So each market is like a group for them, right? So think that if you take Texas as an example, then whole of a Texas is identified as a group. So within the Texas, then you have a counties, right? I mean, this is just a geographical division of the market. So each division is categorized by the county. That means each county is designated as a subgroup. So in this example, for example, in Texas, there is a county called Tarrant County. So that is one of the subgroups. Then further, it is subdivided into a class and a plan. So let's see what is this class. Class is again another subdivision of within the same geographic division. Within the county, there are some cities, right? So each city will be designated as a class. So for example, here, CD01 within the Texas, they have identified as a Medicaid market for the city called Fort Worth. ST Worth is a geographic small division. That means that is identified as a class. So CD1 is designated as a class within the county, Tarrant County of the Texas. Similarly, each class will have a plan. So that particular plan actually identifies the population. What type of population in this example? It is all adult population within the city of Fort Worth in the Texas. They have a plan called sub-TX, etc., etc. So that's how a group, a subgroup, a class, and a plan is defined in the facets. So think that it is just a subdivision of a geographic population, nothing more than that. Just for a simplification of administering the plan and billing purpose, they have to subdivide the members into such classifications. That's all it is. Here is a little bit more, diagrammatically I have explained the same, the groups and the classes. So basically they are groups, subgroup, and class is a geographic regions. Okay. And if you look here, the subscriber is assigned to the class. So always a subscriber will belong to an active class, or it could be a different class like a retired class or a veteran class. So any such classes, always a subscriber belongs to, right? So the class will have a plan, and the plan is always associated with your product. For example, the products can be, if you see an example, pick it up from one of the Blue Cross here, they can have a medical plan, a product, and then there could be another product called spending accounts, and another product called dental product. But within that, they can have a multiple plans, just like, dental, preventive plus, etc. Or if there is a spending account product, it can have a multiple plans, like your health, HSA, HS, flexible spending account, and a personal care. And similarly, a medical plan, you can have your HMO, PPO, POS, etc. Any questions on this? On the right side, what we are seeing here is that gives different factors, in which the premium rates are calculated, or kind of premium rates are influenced by so many factors. For example, area or an industry factors. If you are in the automobile industry, or if you are in mining industry, or if you are in a transportation industry, so these rates depending upon the area where you are in, right? Another factor is your volume calculations. For example, again, if you are in the auto industry, or if you are in any other industry where there is a huge population involved, So there, the company gives group discounts for you, and that would dictate the premium rates. The trend factors, the smoker factors. If there are a lot of smoking population in a particular company, then your premium rates are impacted. The underwriting, the risk adjustment factors, depending upon the age and other factors. So all these factors would go in that would influence your premium rates. So any questions before we go into the programs that run for determining the pricing? Okay. So these are about 7 or 8 programs that we will be talking about. These are the, they don't appear on the screen with these codes, but you'll be seeing some descriptions like service pricing would be SEPC. SEPC is an acronym for the name of the program that runs behind the scenes. So I try to capture some screenshots and give some explanations. So understand that it is going to be a little bit dry because we're not able to talk about more examples on it, but we will go through in each one of them. So before we talk about the service definition and service pricing, let us see the different rules that comprise of the service payments and as well as service definition. The service rules such as your amount, your related services, the penalties, the co-insurance, accumulator pointers, these are the different definitions that are used when you are defining the service payments. Similarly, the pricing part of it, there's a pricing method, there's an allowable amount, there's the pricing prefixes. These are the informations of the rules that govern the service definition part of the program. And for the pricing part of it, again, there is 2 types, right? One is your professional services, and then another one is your hospital or a facility services, or professional claims versus hospital claims. So for a professional claims, then all you would need is your fee, the schedule, the profile optional, then your RNC schedule. So we will be seeing these programs. And similarly for hospital, then there's a DRG, which is diagnostic related groups profile that needs to be defined. Then whether it's a per diem case, etc. And there is a room type profile that would determine the pricing part of it. So there are 2 types here. One is the medical and one is the hospital. So now let us see each program here. The 2 service components, which is your service definition and service payment application. So on the pricing side, the service definition application is used. That means the product component is SEDF. It is a record attached to the provider's agreement. So AGFC is a program that helps you to define the provider agreement, and the service definition program is called upon it. This allows the facet to find a price. So it's the service definition application that helps you to determine the dollar amount for the type of the service that the member is provided. So this is on the pricing side. On the payment side, which is a service payment application, is called in. This is a variable component. Once the facet finds the price, this will tell the facet how to pay. Some examples like how much your co-insurance should be, how much your co-payment should be, your deductibles, your out-of-pocket, depending upon your in-network or out-of-network. So let's talk through this agreement. So agreement is between a payer and as well as your provider, right? So it's an important document. Basically, it is in a contract. So agreement contains the pricing rules. So that is more important here. So it has the pricing rules that providers inpatient and outpatient claims. The agreement can contain a series of related prefixes. Prefixes are nothing but some additional information that drives the pricing criteria. The name of the program is called AGAG, which is in short for agreement. So agreement represents MCOs, which is your managed care organizations. It's a provider's contract with a provider. And the providers can be, for example, a facility, a hospital, a physician. IPA is your independent physician association. So that means a group of physicians who independently operate. Then there's a medical group or a provider group of practitioners. So all these physicians or an IPA, they enter into a contract. So they can vary from provider to provider or can be shared. So depending upon the way they operate their business, they can share an agreement or it can have a separate agreement. The indicator section. So indicator section is one of the sections while you're defining this agreement in the facet. So that particular section contains the facility to update more details like claim, accept months, profile type, risk withhold, and specific information relating to the hospital claims, etc. So what are the different information that you can enter when you are defining an agreement? So we are talking about the three pieces of information like type, profile ID, and override ID. For example, type, it defines the code that indicates the type of the pricing. What is the type? We'll see the screenshot here. That would be mainly used for reporting purposes. The profile ID defines how the pricing profile is linked. That means basically you assign your agreement ID to your profile ID. And in case of override, you will be using the corresponding profile ID whether it is not linked to a provider or not. The other information that we will be using is your outpatient pricing type. For example, whether it should be ASC. ASC stands for ambulatory surgical center pricing, or it should be based on DRGs, or it should be based on per diem, or whether it's inclusive, etc. And if it is an inpatient pricing, again the similar logic, what should be the case for these different types of pricing. So there are different, again, continuation of this indicator section. The discount section tabs, what are the discounts that needs to be applied. Payment section indicates how the claim should be processed for the payment. So basically, it's driving you the whole logic that in which a claim adjudication should happen. The related prefixes tabs, these are the different tabs in which you will be entering the information after information when you're defining an agreement. Some of the examples are your service definition, your exclusions, and multiple procedures that you can perform, and what should be the DRG rules. Then you'll be defining the auto room type, based upon the type of the room, the pricing is influenced. Then there's stop loss, which is a risk mitigation strategy of the payer to limit the liability. So all this information will form part of the agreement. So let us see this screenshot here. I'm gonna expand it so you could see more details. So this screen, it tells you here the different indicator section tab. The type of the hospital or facility, then you define the type of profile, your agreement ID, what is the overriding factor, your risk withhold, how much of a percentage of the risk, and then networking pricing, the outpatient and the inpatient. Then outliers is your limiting factors, inliers and outliers that you define here, the percentages. So you would certainly, going through the manual, the number one, and also the business rules before you start entering these information.
So Raghu, who enters this information? There's a specific person in the company who enters this information?
This information you will be getting from the claims department, the claims analyst, they will be providing you this information.
Okay.
So you would not able to determine what this information is, because this information is so critical that, based upon the agreement, based upon the data that you configure into the system, each and every claim will be processed based upon this. So any minute error in terms of percentages, your whole calculations would go wrong. So it's very, very critical. And in case you are working on this, I think it's better you double check the values and also do a thorough testing of the claims. And I think you should work with the claims analyst at the same time, make sure the values, the right adjudication is happening for the different types of claims and the facilities also.
So that means this interface is used by claim department. in the
Yes. Yes, that's right. Basically, the plan administration, the program data management, these are the different groups within the organizations. They would be using this configuration, basically. It has got a very restricted access. Normally, most of the team members won't get an access to it. In case you are on this, I think that would be very, very highly sought after skills. You'll be developing it. So another section that continuation of the agreement is defining the network details. The network relationship with the provider, should be your network ID, a network prefix, and agreement ID. Remember, this agreement ID is between the network and the payer. The network section in the provider application is used to list all the participating networks who are within that network. That's how you determine your in-network and out-of-network cost. Then the network provider relationship, the program is NWPR, is the one that links the provider and agreement to one or more product structures and identify the proper pricing arrangement. And this is another screenshot that I'm showing you to show an example. How does this network screen looks like? So network ID is right here, the effective date, whether you have a PCP, which is your primary care physician, yes or no, and what are the prefixes that are used, and what is the agreement ID. So your network ID and your agreement is tied up here. That's how your billing will take place. Now let's talk about service pricing. The program is SCPC. It is an integral to all pricing methods. Basically how the pricing is to be determined. That includes the price IDs which point to specific methods. Once established, these IDs link to the types of services via the service definition application. So it has got two components here. One is pay profile amount and one is a service pointer. The pay profile amount is the one that we check it to indicate that the profile price takes precedence over the pricing. So it's kind of gives you an overriding factor. And the service pointer is used to point out the different rates for different types of providers. So it's all about the pricing here. So what are the different pricing methods? So one is the DRG, which is you assign a DRG for a group of codes. Then it could be a DRG or a per diem per case, or it could be as per the schedule. They have a different schedule of payments. One is RVS. I'm not sure what the full form is, but remember that's one of the pricing methods. One is a reasonable and customary method. They go by the rate or anesthesia or some inclusive of room and board per diem, based upon the boarding. Okay, then there's a charges rule that tells factors how the price claims if the amount charged is less than calculated allowable amount. Some kind of a business rule this is. Okay. So in this example, let me make it big. All right. So here are the rules that we configure. You select the profile and the service pointer, and the rules here, whether it has to be default to the 5-digit procedure code or a 7-digit procedure code, and how much of anesthesia in minutes here. If you have to use some conversion factors, then some of the prefixes here. So it's all parameter driven. So some of the key things that we need to remember here is for every type of service, you should have a service price ID attached to the service definition. So just like we have your network ID tied up to your agreement ID, so we also need to have a service price ID. Then there are some indicators, like a professional, in case there is a professional services provided by a facility, how you should do it. And if there is professional bills, facility services. Basically, if you're going to a hospital, but you are billed as a professional, that's what this FACI means. And PROF means if there is, if you go to a same day physician, but in case he thinks that you need to be staying in that hospital for a day or two, then that you should treat that as an inpatient, right? So how the billing should be effective? That's what these indicators mean. So the service definition, we have seen the service pricing, and now let's talk about the service definition. So this is the basis for pricing the member benefits. So it is required prefix when building an agreement. So another critical component of an agreement. The prefix built on a component prefix description application under the medical plan application. So this is the program within the facet. It allows different referral, pre-authorization, capitation, risk, withhold requirements, which are part and parcel of the agreement. So all service IDs are configured on every service definition. Okay. And once the service definition prefix is configured, it gets attached to the provider's agreement via related prefixes. So similarly with the service ID, there's a service definition prefix also gets tied up to the prefixes section. The service pricing is attached here to the service IDs and type of services. So this is another example to show you the screen, how this service definition okay. So here is a service ID and a pricing ID, and here it tells you, for a particular pricing for a code of 00113, what would be the description here, and the type of the room that tells, and also how the billing is to be done, whether it has to be capitated or it has to be a fee per service, and what should be the risk withhold. So all that parameters are shown here in the particular screen of service definition. There are some exclusions. The program is called AJPD, which it helps you to identify what the exclusion means. For example, if there are any high-cost drugs or a DME, durable medical equipment, there are some medical equipment which are not covered as part, like for example, Medicaid or Medicare. So the program that allows you to exclude, and so that you are not billed, it does not pay for it. So those exclusions, the program allows you to exclude.
So this one is inside the facet, or like it's outside?
No, every screen that we are talking about in terms of programs that are configured is all within the facet.
Okay.
Yes. So these are the information. It's better upfront in case you are working on it, like all your exclusions, the different services that are not covered. And then here in this particular slide, you are telling what are the types of exclusions that can happen. Like it could be a normal, or it could exclude from stop loss. B is to exclude, then C is to include in, and then exclude from the stop loss. So different combinations of exclusions can be applied. Just a screenshot of how the exclusion parameters are updated. The different methods is like a C or A or an F. Then in the bottom screen that you are seeing the dollar amount, the percentages, and also the explanation during the claims processing. I mean, the idea is at least you will get a familiarity. You won't be able to go and directly apply the changes, but at least you will know the look and feel of the screens that you need to work on. So the common explanation codes in the exclusion table are INC, means for per diem per case. For a agreement discount, then you use a code DIS, GI18 not allowed under contract, etc. So this may not be an exhaustive list. Again, it's better you look up into your facets manual to get the complete list. So the second type of billing we will be talking about is the ASCs. The programs that we talked about before are in the facets that you defined. Then now is another type of a billing altogether. It is called ASCs, meaning ambulatory surgery centers. So these are identified by the group of physicians. That means the reason of identifying an ASC is because if a member, who is a patient, that if you want to go to a bigger hospital for a treatment, in case he's not able to get the services at the time that he wants to, and if there is some delays in it, and there are some facilities that he's looking for is not available, then there is some alternative means in which he can get the services. So the alternative centers where the physicians provide the same service at a better cost at the less number of time, these are the services called ambulatory surgery centers. That means they are specifically specialized services that provide the services to the patients. So for your information, I have given some of the examples here. Like for example, Health South Corporation is one of the biggest in the country. It has a large number of centers. Then I've given a link here actually if you want to go ahead and find out more details. United Surgical Partners is another chain of surgical centers that operates. So how the pricing happens? So let's see. Starting in 2008, Medicare is actually started. So for the purpose of billing Medicare, these centers have started, and they have actually extended to the Medicaid as well. So the services that are covered under ASC are like example, the nursing, the recovery care provided, anesthetics, the drugs, supplies, etc. So the ASC is a surgical center, and the services are some of the services that I have listed, and type of the billing they provide. It's called a methodology, and that methodology is called outpatient prospective payment system. So here's a slight definition for it. Medicare pays for the related physician services, and the services that we are talking about are surgery, anesthesia, okay. And the new payment system will set payments for individual services. That means they have identified some services, and each service has a fixed amount that a physician has to charge, and that particular amount is reimbursed by the Medicaid or the Medicare. So no matter in any part of the country that a particular service is provided, it has the same cost. So that is the significance of a billing at an ASC, which is also called as outpatient prospective payment system. So this is just a diagram that I've provided to you to get an idea how a payment is determined. There's a big logic to it, but just to understand, what they would do is they would gather the information from the local area where the ASC has been determined or located. So they would gather the wages for a labor and a non-labor, get a 50% of both, okay, and apply a conversion factor. It could be some percentage factor to it, and then at the same time, relative weight of all the resources and requirements of the services. Basically, they look into the optimum resource requirements are needed to provide the services. You take that into a factor, and then you determine the payment. So these are some of the criteria that goes into determination of the payment for these services. So for the ASC services, there are some like over a dozen of the services which I will be showing you. So each service, there's a fixed amount that they have fixed it. So this is the logic behind how the outpatient prospective payment systems are determined. So APC pricing methodology is the continuation of it. It's ambulatory payment classification methodology. So we talked about in the previous in the pricing, and that methodology is called ambulatory payment classification. And for all the services provided by the ASC, which is ambulatory surgical center, the pricing is called ambulatory payment classification methodology. So here the HCPCS codes and the CPT codes are assigned to the APC grouping, and such a group is where the services is provided. So if you look at here, the agreements we are talking about, all par and non-par facility providers need an agreement, meaning all participating in a network and who are non-participating also, still they need an agreement. So there is no agreement, the claim will need to be routed to the pricing configuration to find a price for the service. Okay, so that means to determine the right prices, it has to be having an agreement. APCs. If a service line is not pricing the APC methodology, zeros will be indicated. I mean, this is one of the business rules that we will be working on it. When we are putting together some rules that govern the billing logic. Any questions on this ambulatory surgical centers, ASC, or APC, which is the pricing methodology? So in the FACET system, when you're updating this particular ASC or APC data, the program that is used is called AGHI. So allows the designation of parameters to be used when the pricing multiple ambulatory procedures performed on the same day. So basically that you go to an ASC because they are providing the service for the same day. The percentage level group contains the parameters used to price multiple ASCs performed the same day. So here is a screen that where you can update the ambulatory surgical pricing information, the percentage levels, every service they provide has got some multiple service lines, isn't it? So the first level of service lines, how much percentage should be applied? The second line, how much percent? So these are the different percentage levels they have indicated here. Then what should be the default? What should be the room type, etc. So all these parameters determine the pricing ultimately. The profile pricing. The fee schedule application stores a fee amount for specific procedures. In this particular screen, the application may be used both with schedule and reasonable and customary pricing arrangements. So this is where you define the profile of the price. So here a screenshot just to let you know the procedure code and the service pointers. And for each procedure code, you have an amount here. And this is a percentage of the discount that needs to be applied and from which effective date. So this is your pricing profile screen. Similarly, there's a fee schedule screen that will give you, for effective date and a termination date. Between these 2 dates per particular schedule, how much of a percentage should be applied on the rate. So just like we have a pricing profile, we have a fee schedule profile. Then there's another type of pricing which is called DRG. So this is similar to the ASC or APC we just talked about, ambulatory pricing, and this is based upon the DRG. The previous ambulatory pricing was based on the HCPC codes and the CPT codes. The group of codes were identified together to determine the price. But here, it is based on the ICD codes. So that's the fundamental difference between the APC and the DRG. So what are DRGs? DRGs, they stand for Diagnosis Related Group. It uses the ICD-9 codes and procedure codes as well as the patient demographic. So similar, in addition to the diagnostic codes, they also consider factors of demographic information. So right now we have around 747 clinically cohesive groups. That means there are 747 DRG groups, but these groups get updated every year. In the month of October, normally we receive a file from the CMS, and every organization, payer or a provider, they do an update. So certain types of hospitals are excluded from the DRG reimbursement systems. So it's up to them. It depends upon the type of contract they have. The factors that go into are the base rates, wage indexes, the weights, and other DRG components. The codes are remapped, new DRGs are created, and some DRGs are retired if they think they are obsolete. So there are 2 types of pricing in this particular DRG. So one is done at the negotiated rates. So that means every hospital negotiates its own rates with the payer, so which is basically your standard rate. For example, the Blue Cross has a Blue Preferred or an HMO Blue Choice, so it's a standard rate at which this DRG pricing is done. And the second one is a normal resource consumption. Here, the patient's normal resource consumption is the average amount of resources used to treat any given condition. That means they take an average, determine the price, how much they are, how much price has been determined, and depending upon the food consumption, the medication, etc. So that's another way of determining based upon the historical data, basically. So the Medicare assigns a numeric value, a weight to each based on the normal weight of the resources consumed. And that is called your DRG weight, which determines the DRG pricing. DRG weight along with hospital's base rate is used to determine DRG standard pricing. And to calculate the pricing for the standard DRG, you will need to know the DRG grouper for a patient's discharge diagnosis. So just a grouper means a number that assigns to a group of a DRG codes. These are according to the diagnosis and procedure codes as well as some other demographic information. These are the rules that govern the DRG pricing. That's all we are talking about. So what are the services in which these payments are provided, or ambulatory services are provided? For example, outpatient system, inpatient system, or ambulatory surgical centers, HHA is your home health, IPF is your psychiatric, and IRF is your rehabilitation, LTC is your long-term payment system, SNF is your skilled nursing facilities. So these are the different facilities, in fact, where they provide the services, and the pricing is based on the DRGs. Okay. So continuing the discussion on the DRG, so let's talk about what is the input that goes into this DRG when you're defining in the facets, and what would be your outputs. So the principal input or the data that is used is your diagnostic codes, the secondary diagnostic codes, the procedures, the age demographic information. Then what it tells you, or the output that comes out of the screens, are your major diagnostic categories, the category of diagnostic codes, then the DRGs, then the identification of procedure codes assigned to DRGs, and then if there is any invalid data, for example, your demographic information, so you would throw out as an error. So here is a sample screenshot, how a DRG is assigned to a claim, basically. And the software here is used is an Ingenic software. So they are the ones who are authorized by the CMS to publish the DRGs and implement. And one such claim that we are talking about is your respiratory abnormal indices. And for that, the identified DRG is 786.09. And for that DRG, the price is $112.49. So there's a big calculations behind the scenes. And for us, it looks simple that, for one particular code, so this is the price. Ultimately, it comes up and tells. So just to give you an idea, what are the different rates that are applied? So this particular screenshot will tell you what are the different parameters that are used. This is just for your curiosity to know. So there's a labor-related, the regional, national, MCF cost.
Raghu, what is the screenshot?
Yeah. What's the question?
Where is the screenshot for the previous slide?
Okay, let me go back. Yeah. Yeah, tell me what is the question on this slide?
No, previous slide.
This one?
Yes.
Okay. What is the question here?
You told that you show the screenshot of the system.
No, I was telling you that these are the input information into the system, which is a facet.
Oh, okay.
So you need to input this information, like all these diagnostic codes and demographic information. And once you have input them, then once a claim comes for adjudication, it automatically calculates the price. And for this, I was showing you as an example. For example, the diagnostic code it assigned was 786.09, and the price it determined was $112. And in the next slide, it shows you, sorry, this particular slide tells you what are the different rate components behind the scenes. Because Rate Manager is a big it's a big algorithm. It's called a rate engine, and it's a big software by itself. So every day we'll be getting the files from the CMS and from this company, the vendor which we are talking about is Ingenix, and it constantly get updates. So there's a lot of factors, the rates factors that go into to determine the final price. So just for your information, I'm showing you this slide, which tells you the different pricing factors that are applied.
Okay, yeah. Previously, we couldn't see the screenshot. That's why I was wondering.
Okay. So when you are defining this DRG rules in the facet, so the agreement is linked to the DRG pricing. So again, so critical that we have been talking about this agreement. It is linked all the time to the service prefix. DRG rule tables defines the accepted DRG codes, the pricing associated with these codes, and that sets the outlier, the limits basically, and stop loss is your parameters for your liability coverage. DRG profile is also required and houses the case rates for each DRG configured. Okay, and DRG ID is required on the service definition table. So these are the different tables in facets that you define and you assign these DRG codes. So here is a screen that can give an idea of how it is updated. Here is a sample DRG code description, the pricing type, the amount overrided, etc., and if there are any weights, and these are the inliner and outliner limits that needs to be applied. And at the bottom, it tells you what are the different codes and the limits here. So again, it's all parameters driven, and that determines the business rules for the pricing based upon the agreement. Here is the DRG profile screen, and I have given an example here. For example, here the DRG 373 in this example here, which has an effective date and there's no termination date, and that has an amount here. So whenever there is a DRG code of 373, there's a fixed amount of $2,001 charged. So it's that simple. Okay, so another, we are basically covering the different pricing parameters, right? So there's another program that enables you to enter the room types, because the room types is also one of the factors that changes your pricing. The room type identifies the type entry that requires to obtain pricing values for all inclusive rooms and board and as per diem per case hospital claims. So the members who get admitted as an inpatient. During the claims processing, the room type is automatically generated based on the criteria you entered. So once the room type is found, the correct pricing of the room is determined. So this is just for your theory of how the auto room type is used. And here is a screenshot that helps you to understand the room type, the effective, the date, the revenue codes, the procedure codes, and the room type here is a 20. It's a 2-digit code that we assign. And we are saying that revenue codes must be entered with the leading zeros. So revenue codes is for the room type, and based upon the room type, the charges will change. Enter the room type codes used when all the same parameters match during the hospital claims processing. So continuing more information on the room type profile, it identifies the different room types and how the rate should be calculated. For example, if it's a medical or professional claims, or if it's a surgical rooms, ESC case, emergency case rates, etc. And it has got a couple of tables, tabs that tells you about the indicator section, more information to be provided. The That means it will help you to calculate any discount associated with a particular room type, or to be used the rates associated with a particular room type. Here's a screenshot that tells you to update the discount allowable. A is for allowable, C is for charges, and L is for discount. The discount type and the risk sharing amount, percentage, and some explanation codes here. Another piece of information is the units at the bottom here, like how many units, and for them how much it has to be charged. The units and amount that needs to be entered for the room. So last but not the least, the program is called AGSL, which is your stop loss program that needs to be configured, when you're at the time of defining the agreement in the facet. It's basically used to define the dollar amount with an MCO, which is your managed care organization, because they would alter the standard agreement pricing logic to limit the liability at any point of time, because if due to some reason the costs are increasing, and there should be some coverage to protect the insurance companies. So that's the reason this particular program, the stop loss, would help them to minimize the risk. So first one type is called large case dollar, first dollar, which applies the discount to the first dollar of charges after the threshold is reached. If the amount is over the threshold amount, the whole amount is subject to the discount. That means if you have reached certain percentage or some fixed dollar amount, the complete dollar amount is subject to a discount. That is called your large case first dollar. The second type of discount that are applied is large case above threshold. Applies the discount only to the amount that exceeds. That means only the amount that exceeded that limit, that particular amount, the difference, that delta amount only is subject to the discount. So as an example here, we are saying that a large case dollar with a threshold of $50,000, where a claim will be priced at 65% of the billed charges. Okay, and currently stop loss language is also entered in the note section. So different parameters that needs to be entered for this stop loss. Any questions on this? I mean, the material that is provided try to give you more snapshots, how they look like and what parameters that you need to be aware of. That was only the idea of today's class. Then a data model is another thing that would be highly helpful to you to understand some of the tables and what data they contain. So I can show you some other examples of talking about this data model. Here. Here is a sample data. Okay, sample data of claim table. So here is a claim ID. Then there's a claim number. Then I was telling you about the GRGRCK, which means the market. That means there's a code here, market code. It could represent a particular state. Okay. Then the claim type, medical, subtype. There's some of the values here, some of the dates, date and time. HIC number is your CMS assigned. Basically, it is your SSN number followed by prefix. Here, this prefix tells you what kind of a relationship a member has to the subscriber. The provider ID information here. Here is a patient account number. Remember, the patient account number is sent by the provider. Okay. A huge table. Okay, that's it. And then the next column that I'm showing you is the claim lines. For every claim in the claim table. So here, for example, I'm showing you 3 service lines. So there's a claim number here, and there's a claim sequence number. That means there's a service line 1, service line 2, and service line 3. The provider ID, the codes here, HCD codes, the charge amount at line level, amount not allowed, that's it. So let's see the provider information. It's a small table here. Provider ID, name of the provider here, it's one of the hospital, the NPI, National Provider Identification Number, taxonomy code, so let's see the provider address. It's just the address here. So this is the provider ID and their address here. So this is the street address, city, state, zip, county. So it's very easy. The information that's available in these tables are quite easy here. So not that complicated. So once you know a little bit. So this is the coordination of benefits. So I don't have the data here, but this is how the tables and the column looks like. Any questions on this table data? Or anything that you want to comment? I'll put all the information that we just talked about as a separate document so you can print it out. So that's what I would do. And I know a couple of you have emailed me the questions too, so I'll be putting them in the blog as well. So do you all feel that Yes, Kamal, tell me.
No, I was about to tell you, put the information in the blog. You already told me.
Yeah, the questions I will be responding back in the blog because in the last session in the last session, a couple of you all have emailed me the questions and I didn't have a chance to look at it. So tomorrow I will get back to them. And we will keep the blog active. So if you want to ask me any questions, so feel free. And if you need any more other project documentation, yes. If you have some time, I can show you some sample project documentation now. Let me do that.
Yeah, we want to see.
So let me start with the project charter. So here, this is a project charter. Any company will have a project number here. I mean, I've blacked it out so that we could protect some of this information. The sponsor, name of the sponsor, who are the key stakeholders here. As a business analyst, you would not be involved in drafting the project charter in most of the time, but in some cases, yes, you would be involved, and you will be providing the key information to the PM. So the PMs are the one who will be drafting the project charter. But it's important that you understand the project charter. For example, the business case is the one is very, very important. So that will give you a basic objectives of why we are doing this project, who is the one who's going to get benefited, what are the goals, what is that we are going to achieve, and what are the consequences if you do not implement this project. And you'll see some goals and objectives of doing this project. What is in scope and what is out of scope. I mean, this is a very brief document. Project charters are mostly 2-3 pages or, a 1-page, 2-page document. So this document will not be as elaborative as your BRD. And yeah, you have your team members, and then finally who is approving this document. So it's very simple, straightforward document, project charters. And let me show you the other documents. Let me show you one of the business requirements document here. The different version control information, who is reviewing it, and some of the acronyms that we use, the table of content, background information, what are the business goals, success criteria, what is the business model. Depending upon the organization, you might have this, some organization might use, if you're using the rational rows or use cases method of documenting, then you will certainly have these actors, the business model, the current process model, the target process model, and the business use case diagrams. So it depends upon the type of the organization culture. So the brief introduction, I mean, every document has a brief introduction, the background information. And the success criteria is very, very important, because when you're writing your business cases, always think that what is your goal that you need to achieve. For example, here we are trying to reduce 44% the claims, increase the claims volume from 44 to 50%. So are we able to achieve it or not? And then you are saying that there's a 2.4 FTE reduction. So these are a very, very critical parameters, and unless your business owner agrees to it, so we should not put it. So we should be very careful when you are putting such a metric, and if it is not achieved, then that would show your project in a bad taste. So business actors, who are the key stakeholders would be involved. The process model here, the current, as is, and target or to be. In scope, out of scope, and this is the business use cases. That's how it is written. I mean, there are different ways you can write a use case. So a scenario basically. And this table is called your requirements traceability matrix. So as a BA, I think it's very important that you maintain such a requirements traceability matrix, and it is maintained throughout the life of the project life cycle. Right. I think that's about it. Maybe I'll show you some gap analysis document, which if you're going, you will be preparing the gap analysis as well. Okay, so here is a document that tells you each and every segment. For example, if you are moving from 4010 to 5010, under the 4010, what are the elements that are getting changed? So here is on your right side, each and every element, and that tells you, is it a new, is it deleted, is it relocated, is it used as per the TR3 document, what are the qualifiers? So it's kind of a color coded, so easily tells you. So this is what you will be doing, a mapping or an interface when you're converting a 4010 to 5010. Any questions or any other specific document that you would like to see?
Raghu, can you show this UML use cases?
The BRD document which I just showed you?
No, functional requirement document.
Yeah, in this case, this is the functional requirement document. The BRD business requirement document is called a functional requirement.
Oh, what about the graphical use cases?
Yeah, in this organization, they did not use the graphical representation of the use case model. So it does not have it.
Oh, okay.
So they are using this tabular format of use case. So the first box is called business use case, number 1. That's it. So in some cases they use the actors and use some graphical picture, but here they have not used it. Okay. Especially if you are using a rational rows tool, you'll be asked to develop those use case models, but otherwise it's not required. Okay.
So Raghu, like the project, the documents that you just showed, like if we need to go for a project, how long that project would be? Like 3 months?
If, for example, if you are going on a mapping, on a 50-10 project, 50-10 project would end up in January. So this is September, right? October, November, December, January. That would be only 3 to 4 months project. And mostly the projects that would is your enhancements of regular claims processing. And I would suggest that given a choice, most of the time you may not have a choice, but if you have a choice, go on EDI transactions. So it's always there. So there's always an upgrade to the EDI system, EDI transactions. So that's changed from time to time. So that's one area where you can see a lot of changes coming in.
So like, what about this ICD-9 to ICD-10?
Yeah, ICD-10 has got some time. So now only once the 5010 is implemented, so that will be laying a foundation. Basically, all your data model will be updated to accommodate the ICD-10 changes. So only next year, the actual work on ICD-10 will start. So right now, it's only some readiness assessment is happening right now in all the industries. So you have to wait till first quarter of next year to get some really work started on ICD-10. And the implementation date for the ICD-10 is October 2013. So we got around 2 more years to work on ICD-10. And ICD-10 would be mostly on the business side of the organizations, most of the changes. So that's another good opportunity if you want to get into the business knowledge or the business processes. So get some projects on ICD-10, that would be great.
Okay, thank you.
Yeah. All right, guys, then it was a pleasure giving you some basics about this domain. So I think we touched about, not each and every aspect of healthcare, but at least some of the common domains where we can, when we go onto a project, we can find these areas pretty much, using, and to help you to prepare for your interviews. I mean, that was the idea of providing this 10, 12 hours of, healthcare training. All right, so I will certainly, put all these documents, what I showed to you on the blog, so you can look at it, review it,